Every opioid we've covered so far gets cleared by the liver, or occasionally the kidney. Today's drug breaks that rule entirely. Remifentanil doesn't care whether your patient's liver is functioning at 10% or 100%. It doesn't care if they're in renal failure. It gets destroyed by enzymes floating around in the blood itself, everywhere in the body, all at once. That single fact is going to explain almost everything that makes this drug so completely different from everything we've discussed before it. The structural twist. Remifentanil is still a phenylpiperidine, still structurally related to fentanyl, still working through the same μ-receptor we've talked about in every opioid lecture. But somewhere in its structure, the chemists building this molecule tucked in an ester linkage, a chemical bond that ordinary enzymes in blood and tissue can simply snip apart. That one design decision is the whole story. Think of it this way. Fentanyl gets around the body on foot. Remifentanil skips the sidewalk entirely. Potency. Analgesically, it lands in roughly the same neighborhood as fentanyl, and it's about 15 to 20 times stronger than alfentanil. But potency isn't really the headline here. Speed is. How the receptor side works. Nothing unusual to report. Mu receptors dominate, kappa and delta barely register. Activation gives you the standard package: analgesia, sedation, anxiety relief, a touch of euphoria, pupil constriction, and respiratory depression you need to respect. Onset and offset. Where this drug separates itself. Onset, within 1 minute. Peak effect, roughly 1 to 3 minutes. A single dose runs its full course in 5 to 10 minutes. Compare that effect site equilibration time, 1.1 minutes, against fentanyl's 6.4 minutes. That's not a small difference. That's a completely different category of speed. The drug isn't just reaching the bloodstream fast, it's reaching the brain fast and leaving just as quickly. Where it goes in the body. Remifentanil's volume of distribution is small, around 0.3 to 0.4 liters per kilogram. Nothing close to the enormous distribution volumes we saw with fentanyl soaking into muscle and fat. Clearance runs around 3 liters per minute. That's roughly 8 times faster than alfentanil gets cleared. And critically, that clearance rate barely varies from one patient to the next. Predictable pharmacokinetics, low interpatient variability, a genuinely rare quality in opioid pharmacology. The metabolism story. This is the part that makes remifentanil a genuine outlier. It gets broken down by non-specific esterases sitting in plasma and throughout tissue, not the liver, not the kidney, and notably not plasma cholinesterase either. So patients with atypical cholinesterase aren't affected the way they would be with succinylcholine or ester local anesthetics. The breakdown product, remifentanil acid, is somewhere between 300 and 4,600 times weaker than the parent drug, and for practical purposes, inactive. That acid metabolite then leaves the body primarily through the kidneys, but since it's essentially pharmacologically silent, even significant renal impairment doesn't meaningfully change the clinical picture. Elimination numbers. Distribution half-life, 0.9 minutes. Elimination half-life, 6.3 minutes. Context-sensitive half-time, approximately 4 minutes. Every one of these numbers is dramatically shorter than what we saw with fentanyl or sufentanil. The defining feature, context-sensitive half-time that barely moves. Remember how fentanyl's context-sensitive half-time climbed steeply the longer you ran the infusion, because the drug kept loading up muscle and fat tissue reservoirs? Remifentanil essentially doesn't have that problem. Run the infusion for 10 minutes or run it for 10 hours. The context-sensitive half-time stays close to that same 4-minute mark. Because plasma esterases are chewing through the drug continuously, everywhere, independent of which tissue compartment it's sitting in, there's essentially no way for it to accumulate. Line this up against the rest of the family. Alfentanil's context-sensitive half-time lengthens with infusion duration. Sufentanil's lengthens too, though less severely. Fentanyl's lengthens the most dramatically of the group. Remifentanil barely moves off its baseline at all. This one property is arguably why remifentanil exists. It was designed specifically to solve the accumulation problem every other opioid infusion eventually runs into. Dosing. Analgesic bolus, 0.25 to 1 microgram per kilogram IV, blunting the sympathetic surge around intubation, 1 microgram per kilogram IV. Continuous infusion for general anesthesia, 0.05 to 2 micrograms per kilogram per minute. MAC sedation, 0.05 to 0.1 micrograms per kilogram per minute, can be paired with midazolam or propofol. Why you'd actually reach for this drug? Total intravenous anesthesia, TIVA, is a natural fit, given how precisely titratable it is. TIVA, total intravenous anesthesia, is often preferred during intraoperative neuromonitoring because it provides more reliable preservation of neural signals, with less suppression of evoked potential amplitudes and less effect on signal latency than inhaled anesthetics. Propofol and remifentanil are commonly used for TIVA because both are highly titratable and have rapid onset and recovery characteristics. Neuroanesthesia, where you need rapid, predictable recovery for neurologic assessment immediately after the case. Awake craniotomy, where the patient needs to move seamlessly between deep sedation and full alertness for cortical mapping. Wake-up tests, such as during spine surgery, where you deliberately bring the patient back to consciousness mid-procedure to check neurologic function, then return them to deep anesthesia afterward. Brief but intensely stimulating moments. Laryngoscopy, positioning, sudden bursts of surgical stimulation, where you want strong coverage that disappears just as fast as it arrived. The advantages across all of these: precise titration, rapid onset, rapid offset, essentially zero accumulation, and predictable recovery no matter how long the infusion has run. CNS effects: analgesia, sedation, anxiolysis, pupil constriction. The expected list. It also lowers cerebral metabolic oxygen demand and reduces cerebral blood flow, same direction as the other opioids we've covered. The headline number worth remembering? That 1.1 minute effect site equilibration time. This drug reaches full brain level effect faster than any other opioid in routine use. Respiratory effects. Respiratory rate drops, tidal volume drops, response to CO2 gets blunted, the standard opioid pattern. But there's a warning worth taking seriously here specifically. Combine remifentanil with propofol, and you get profound synergistic respiratory depression, significantly more than either drug alone would predict. This combination is extremely common in TIVA technique, which makes it essential to monitor respiratory status closely whenever you're running these two together. Cardiovascular effects. Mild hypotension, mild bradycardia, generally stable hemodynamics overall. No significant histamine release, consistent with the rest of this drug family. No meaningful increase in intracranial pressure, which is part of why it fits so well into neuroanesthesia. The adverse effects that are genuinely unique to this drug. Beyond the standard opioid side effects, respiratory depression, bradycardia, nausea, vomiting, sedation, remifentanil brings a set of complications that are more specifically its own. Chest wall rigidity, same phenomenon we saw with fentanyl and sufentanil, tied to rapid administration. Rare seizure-like activity has been reported, and two phenomena that deserve their own extended discussion: post-infusion hyperalgesia and acute opioid tolerance. The exam favorite concept: hyperalgesia and acute tolerance. This is arguably the single most tested concept associated with this drug, and it's genuinely counterintuitive. Run large intraoperative doses of remifentanil, and instead of your patient waking up comfortable, you can actually see the opposite: increased postoperative opioid requirements, and in some cases, genuine hyperalgesia, an exaggerated, amplified pain response. The patient who received the most potent, most precisely dosed opioid of the entire case can end up needing more pain medication afterward, not less. The proposed mechanism runs through NMDA receptor activation, along with changes in intracellular second messenger signaling. Essentially, sustained high-dose opioid exposure appears to sensitize pain pathways, rather than simply dampening them. To prevent this, providers commonly use ketamine, given its NMDA antagonism, magnesium, which also has NMDA modulating properties, and critically, transitioning the patient to a longer-acting opioid before the remifentanil infusion ends. That last point deserves its own emphasis because it connects directly to remifentanil's defining pharmacokinetic trait. The most important practical warning, because remifentanil clears so completely and so quickly, stopping the infusion doesn't leave behind any meaningful residual analgesic effect. Unlike stopping a fentanyl infusion, where redistributed drug in peripheral tissue continues providing some coverage for a while. Turn off remifentanil at the end of a case without having given anything else, and your patient can wake up with essentially zero ongoing pain control. This is why the standard practice is to administer a longer-acting opioid, morphine, hydromorphone, fentanyl, before you discontinue the remifentanil infusion, timed appropriately so that coverage is already established by the time remifentanil's effect disappears. Forget this step, and you'll have a patient in significant pain in recovery, completely unprotected. How it compares to the rest of the family. Remifentanil, roughly equal potency to fentanyl, onset about 1 minute, duration 5 to 10 minutes, context-sensitive half-time around 4 minutes, essentially flat regardless of infusion length. Fentanyl, same reference potency, onset 1 to 2 minutes, duration 30 to 60 minutes, but context-sensitive half-time that climbs steeply with prolonged infusion. Sufentanil, 5 to 10 times more potent than fentanyl, onset 1 to 3 minutes, duration 20 to 45 minutes, intermediate context-sensitive half-time. Alfentanil, about 1/10 of fentanyl's potency, onset around 1 minute, duration 10 to 15 minutes, also intermediate context-sensitive half-time. Look at that table and remifentanil stands alone. Every other opioid in this family accumulates to some degree with prolonged infusion. Remifentanil essentially doesn't. The high-yield summary. Remifentanil's ester linkage is metabolized by non-specific plasma and tissue esterases, independent of both liver and kidney function. Clearance runs around 3 liters per minute, effect site equilibration time, approximately 1.1 minutes, the fastest in the opioid family. Context-sensitive half-time, approximately 4 minutes, and it barely changes no matter how long the infusion runs. Hepatic and renal dysfunction have minimal impact on clearance, no significant histamine release, and large intraoperative doses can trigger hyperalgesia and acute tolerance. Always transition to a longer-acting opioid before the infusion ends. Pulling it together, remifentanil, an opioid engineered around a single idea, metabolism that has nothing to do with organ function and everything to do with enzymes already present throughout the blood and tissue. Fast on, fast off. No accumulation, no matter how long you run it. That precision is exactly what makes it perfect for cases demanding rapid, predictable neurologic recovery, and exactly what makes forgetting the transition plan to longer-acting analgesia such a costly mistake. Give it respect for its speed, give it respect for hyperalgesia, and never let the infusion just stop without a plan for what comes next. I'm Anesthesia Buddy. Stay sharp. See you in the next one.